Good evening, students. We are live now. All of you, we are live now. Good evening and welcome to the Pediatrics quiz on the DAMS Daily YouTube channel. So, how are you all today? So, today what we'll do is we will be sharing with you very important clinical questions from our DAMS question bank, and I will be taking you through important points about almost every a subtopic of pediatrics. So I'll be talking about, say, pediatric neurology, congenital heart disorders. We'll talk about all of those. So all of you, are you ready for a quiz section? And we will do a lot of rapid fire questions. And though I will also tell you who came first, who came second. We'll see who amongst you is fastest. So let's start chatting. And the first question goes out on a pediatric emergency case. So this is a pediatric emergency case, and students, you have to first tell me the diagnosis of this child. So first of all, you have to tell me the diagnosis. So first you'll tell diagnosis and then we'll come to the treatment. So can anyone in the class tell me, this is a 5-year-old boy who comes to me, and you have to tell me the complete clinical diagnosis. No, I'm asking you the complete clinical diagnosis. I'll just get a pencil to look at who was the fastest amongst you, and we'll just declare the name. Okay, so telling the name is enough. Okay, so all of you were right. So this is a child with fever, and he has features of septicemia with a blood pressure of 90/60. Pulse rate is high, respiratory rate is 30 per minute. So I first asked you, what is your diagnosis? So students, I would say actually none of you was exactly completely right, because all of you, this child actually has a septic shock which is compensated. So if you ask me, I would give full points to someone who would have said compensated, because the blood pressure is maintained in this child. Septic shock, compensated septic shock. So let's take you first to what is, and before that I would like to tell you that Dr. Akansha and Dr. Shrishti, they were the first ones to answer here as septic shock, and Dr. Aswathi. Okay, so we'll keep on looking at the top 3 guys. Okay, there are no points for winning, but it's okay in life sometimes, it's okay. So students, what is shock? Shock is a patient who has impaired perfusion. Shock is a state where you have impaired perfusion to vital organs. So hypotension is not required to diagnose shock. So students, hypotension is not required to diagnose shock. Okay, so what you need is evidence of impaired perfusion, by which, first if I talk about clinically, so clinically, number one, of course, heart rate. Heart rate is the sign, because you will always have tachycardia in a patient with shock. It is always there. So heart rate will be always increase in these patients. Looking at the respiratory rate, tachypnea may or may not be there. Tachypnea may or may not be there, especially in cases of septic shock. Those children who have, say, pneumonia. And remember, shock is of many other types. Shock can be a obstructive shock. shock can also be, so if you have a patient who has, say, tension pneumothorax, in tension pneumothorax there is obstructive shock. In tension pneumothorax there is obstructive shock. So these patients may have increased respiratory rate, may have asymmetrical movements of the chest. Okay. Now blood pressure. Remember, if I classify shock based on, whether it is compensated by the sympathetic stimulation or not, I can classify shock based on whether it is compensated or uncompensated shock, In compensated, the blood pressure is well maintained. Only the blood pressure is well maintained. However, the child is still sick. So remember, however, the child is still sick in a case of compensated shock. So your capillary refill time will be prolonged. It will be more than 2 seconds. Okay. The temperature will also be altered. So your peripheries may be still cool. The temperature between the central and the peripheral skin may be more than 2 degrees. And if there is hypotension, this uncompensated shock may go into irreversible shock. So if it decompensates, if you don't manage that well in time, this can go into decompensated shock. Okay. Now we have a question here. Sir, you are in the emergency. Now, sir, how do we look at what should be the value of the blood pressure? And all of you are wrong actually. First of all, what we'll do is, let us classify blood pressure according to percentiles. Okay, according to percentiles. So the first child in my class is in shock. He is pulseless. He is not having any recordable BP. And the last student of this class has very high blood pressure. Okay. So all of you, if I classify based on age, what is hypertension first? Hypertension is a blood pressure more than the 95th percentile. So hypertension is a blood pressure more than the 95th percentile for that age and sex. So it's based on the age and sex. Okay, so for that age and sex, a blood pressure more than the 95th percentile is hypertension. Now hypertension is also defined as, in children more than 13 years, a blood pressure more than 130/80. In children more than 13 years, a blood pressure more than 130/80 is hypertension. Okay, students? Because in 2017, the American Heart Association came with new guidelines. The American Heart Association in 2017 came with new guidelines for adults for hypertension. So that is why, students, in 2018, the American Academy of Pediatrics came up with new guidelines for adolescents. So for children who are less than 13 years, so on your screen, for children who are less than 13 years, I look at the chart, and a blood pressure more than the 95th percentile for that age and sex, okay, is hypertension. And for children more than 13 years, I don't need to look at the chart. I will say a blood pressure more than 130/80, just like adults, is hypertension in children more than 13 years. Now let's talk about hypotension. What is hypotension? And this was the question just now asked by Dr. Katiyar and Dr. Syam. So what is hypotension? So hypotension is basically a blood pressure less than the 10th percentile for that age and sex. It's a blood pressure less than the 10th percentile for the age and sex. Okay. So now students, especially for our pediatric advanced life support, I know all of you are on the road and you have a sick patient on the road. Now, how do you tell this patient is hypertensive? You can't open the charts on the road. So, this is according to the PALS guidelines, the Pediatric Advanced Life Support, that for a term newborn, okay. So, remember, in the first 4 weeks of life, a blood pressure systolic less than 60 is hypotension. This is the lowest limit, okay. In infants between 1 to 12 months, a blood pressure systolic less than 70. So, in a child less than 1 year, a systolic less than 70, and 1 to 10 years, 70 plus age multiplied by 2. So, let's come back to the question, and all of you in the class, the question which I asked you was a 5-year-old, wasn't it? Yeah, that child was a 5-year-old. So, can anyone in the class tell me, for a 5-year-old, what is the minimum acceptable systolic? And your time starts now. For a 5-year-old, what is the minimum acceptable systolic? You're right. Ayush, Divya, Shivam, you're right. Okay. So that will be, for a 5-year-old, minimum acceptable is 80. So let's come back to this question which I asked you from a DAMS question bank. A 5-year-old, and now all of you agree with me, this child has compensated shock, compensated systolic dysfunction. Okay. Now it is septic shock. So it is, remember, it is basically a distributive shock. So there is peripheral vasodilatation. Now remember, the fluid of choice is normal saline. A rapid bolus of 20 ml per kg of normal saline. So you are right. The answer is C. You have to give a rapid bolus of normal saline. A rapid bolus, it has to be given as fast as possible. Okay. So remember, students, for shock, the drug of choice number 1 is normal saline, which is called 0.9% sodium chloride. You have to give a bolus of 20 ml per kg. In newborns, no, Shivam, the fluid of choice is normal saline. Now, if in newborns, I would start with 10 ml per kg. In newborns, I would give 10 ml per kg, and I will evaluate this child. I look at this child, all of you. I will look at this child. What will I look at? I look at the heart rate. I look at the capillary refill time, improvement in the blood pressure. So I look at the heart rate. I look at the capillary refill time. I look at the blood pressure improvement. Look for the improvement. Okay. Dr. Varun, N/2 is a maintenance fluid. यहाँ हम resuscitation की बात कर, we are talking about resuscitation, guys. So never use N/2 for resuscitation. Never ever. Okay. So for resuscitation, we always use normal saline. Now for dehydration, we have a question by a student here. So first of all, you should log in with your own names. Okay. I don't like name by the name of films. So if you have a name like this, I would not respond to you. Okay. Now, what about someone asked about ringer lactate. Now, ringer lactate can be given for severe dehydration. Okay. So I looked for the improvement. There is no improvement. Now I can go up to a total of 60 ml per kg. Students, I can give a total of up to 60 ml per kg of normal saline. Okay. Okay. Now he is not improving. Now I will be putting a CVP line, students. I need to put a CBP line, because I knew, shock is of many types. Shock can be hypovolemic, shock can be septic shock. It can even be, cardiogenic shock. How do I know it is cardiogenic shock or not? So I need to look at the cardiac filling. So CVP, if it is low, I will give more saline. If CVP is low, I will give normal saline, more of saline. But suppose it's septic shock. And students, you know what? In the COVID era, in children, we see lot of MISC in children. Multisystemic inflammatory syndrome in children with COVID. As I am speaking to you right now, in my ICU, we have 10 patients admitted with MISC, multisystemic inflammatory syndrome. Now, they are slowly getting discharged. Now the peak of MISC in children is also reducing. But in MISC, we see myocardial failure. Okay. You can give a lot of saline. It has been seen, we have a question here by Dr. Ayush. It has been seen that in septic shock, if CVP is low, you can give up to 200 ml per kg. But guys, please give more fluids under CVP guidance. If CVP is normal or high, you deteriorated the patient. We had a question here. You deteriorated the patient. So now I will give him inotropes. And remember students, for a newborn, the inotrope of choice is dopamine. And for older children. Now, in fact, students, what happened last year? In 2020, there were new surviving sepsis guidelines. And those guidelines say you can use either norepinephrine or epinephrine. So now, it is based on the clinician's decision. Okay, so remember, but we don't use dopamine in older patients. If you will ever go to a pediatric ICU, you will see in shock it's all about norepi and epi. Dopamine, the evidence is mostly for newborns, so we have stopped straight away going on to dopamine in older children. Now the things have changed, Dr. Sai. So it's based on the clinician, because there is not much evidence on what to use. So it is mostly norepi or epi. Let's take you further to the second question on the day, and let's talk about SAM. Students, for your exam, definitely SAM is a question, and let's talk about SAM, the definition of SAM. And can anyone in the class tell me what is not a criteria? And the first ones to answer were Mohit, Aswathi. Okay, so Aswathi is still has scored 2 times in top 3. Then we have Mohit and MM. Okay, so Aswathi is leading right now. Okay, so all of you have told us the right answer. Of course, height for age is not a criteria for acute malnutrition. So remember, height for age is not a criteria for acute malnutrition. Okay, so height for age is not a criteria. So let's first take you to the parameters which we use for acute malnutrition. Let's talk about the parameters which we use for acute malnutrition, and let's talk about the WHO classification of malnutrition. Let's talk about WHO classification for malnutrition. Okay, so according to WHO, malnutrition, first of all, you should know the parameters, and the most commonly used parameters for acute malnutrition is weight for height. So remember, weight for height is a parameter for acute malnutrition. So suppose a child is 100 centimeters, 12 kg. He got a diarrhea, his weight reduced to 10 kg. So height is the same, but his weight reduced from 12 to 10 kg. So his weight for height reduced. So remember students, weight for height is a marker for acute malnutrition, which is also called wasting. It is also called wasting. Okay. So remember, it is also called wasting. So it's a marker of acute malnutrition. Then height for age. Your height tells you about, what does your height tell you about? Chronic malnutrition. So your height tells about chronic malnutrition, which is also called stunting. It's also called stunting. Okay. Okay. Okay, which is chronic malnutrition. Now weight for age is a criteria which can tell about both. So it's a very common question asked in All India PG exam, in the NEET PG exam. Which criteria is a good criteria for telling about both acute and chronic malnutrition? And the answer is weight for age. It is for both acute and chronic malnutrition. Okay, so remember that. So SAM is very important. When we talk about SAM, it is severe acute malnutrition. Why are we talking about SAM? Because these children can die. These children are at risk of death. So we need to diagnose SAM early. Okay, we need to diagnose SAM early to prevent death. Now students, you should know this definition from UNICEF and WHO. You should know this definition from UNICEF and WHO. So remember, SAM according to UNICEF and WHO is divided into two groups. So remember, SAM according to WHO and UNICEF is divided into two groups: 6 to 59 months and less than 6 months. 6 to 59 months and less than 6 months. Okay, 6 to 59 months and less than 6 months. Okay, so remember both of these. Now 6 to 59 months, weight for height. So please remember, all of you, weight for height less than 3 standard deviations is SAM. It is severe. So what is severe? Less than -3 standard deviation. Okay, so remember that. Weight for height less than -3 standard deviation is SAM, or presence of bilateral edema or mid-arm circumference below 11.5 centimeters is SAM. Okay, so please remember two age groups, 6 to 59 months and less than 6 months. So ये दो age group याद रखने हैं, and I can bet on this question mostly every time. I can tell you, last NEET PG, last two NEET PGs, this question always came. SAM. Okay, now below 6 months we cannot take mid-arm circumference. So mid-arm circumference is not used below 6 months. So below 6 months you will take criteria number 1 and 2 to define SAM. Okay, criteria number 1 and 2 to define SAM. This is for age less than 6 months. So SAM is important, especially when you talk about, when you talk about malnutrition. The most important point will be SAM. Now talking about emergencies in your exam, here is a child on your screen, and you'll have to tell me, the first one who tells me the diagnosis and the treatment will get the points. Diagnosis and the treatment. A 2-year-old child, guys, all of you are wrong. Lovely to see everyone leaving Ria. Leaving Ria and Namrata. Ria, Namrata. The rest are all wrong. Almost everyone was wrong here. So first two were Dr. Ria and Namrata. Okay, and Yash. So you have a boy here, a 2-year-old boy who comes to you with fever. Barky cough is very classy. Barky cough. And on examination, he has stridor. On examination, he has stridor. Now, stridor is only during crying. So, all of you, what is your complete clinical diagnosis? Okay? Anyone? What is your complete clinical diagnosis? Anyone? What is your complete clinical diagnosis? I said complete, and Dr. Janvi is right. This child has mild croup. This child actually has mild croup. So my diagnosis here is mild croup. So I'll come back to you. Why am I saying mild? Someone here is very persistent saying, sir, ये तो moderate croup है. And आप कह रहे हो ये mild croup है. But this is mild croup. So let's first talk about croup, guys. Croup, which is also called laryngotracheobronchitis. Croup or laryngotracheobronchitis. It is, remember, it is the most common infection of the upper airway. It is the most common infection of the upper airway. It's viral. 75% of croup is caused by a virus called parainfluenza virus. So 75% of croup is caused by a virus called parainfluenza virus. Okay. Now students, I would like to tell you all today a very important point. It's not just about stridor. Okay, लोग कह रहे sir stridor on crying, it is mild, otherwise it is moderate. Students, you have to look at the whole clinical picture. Problem ही यही है हमारी, हम पूरे बच्चे को देखते ही नहीं है, बस एक स्ट्राइडर को देख रहे हैं सब. डॉक्टर साहब, and don't NEET PG aspirant, whatever your real name is, don't thank Dr. Chitra yet. You need to look at the whole patient. Okay. Now we'll talk about the whole patient, not just talking about stridor. So this child has a barky cough after a viral prodrome. After a viral prodrome. Okay. After a viral prodrome, he had a barky cough, he had a stridor. So remember, all of you, viral infections commonly have a barky cough and they have a viral prodrome. Okay. Now, all of you, now how do you differentiate mild to moderate to severe? So let's talk about what are the markers of severity, and this is what I want all of you to know. What are the markers of severity of croup? And someone rightly said here, his name is Dr. Ayush, he rightly said that, sir, we need to look at many things. Whether he is hypoxic, whether he is cyanosed or not, whether he is able to drink or not, inability to drink, whether he has severe retractions or not. Severe retractions or not. And then, yes, stridor at rest, you're right, stridor at rest talks about that this child has a moderate to severe crew. Okay, so देखो आपके एग्जाम में if you have a patient who has a viral prodrome but now he has a barky cough, he's cyanos, he's not able to drink water, he's desaturating, he has retractions and he has stridor at rest, तब मैं बोलूंगा moderate to severe crew. Okay, देखा आपने? So you need to look at the whole clinical picture. Please don't just say sir stridor हो गया तो बस हमने तो बस ये सीखा है सर, स्ट्राइडर के बेसिस पे हम करेंगे. There is a scoring system based on this. It's called Wesley's scoring. That is not important for you. You just remember this and look at the patient. If patient is sick, it is not mild. Okay? Yes. So please look at the whole patient. So why are we talking about this? Because number one, it is a very common question. This question comes every 2 years in AIIMS. I can tell you the years. We've been at DAMS, we are following these exams since almost 20 years. I'm teaching in DAMS since 2004 and today is 2021. So since last 17 years we are following these questions, and I can tell you this question comes every 2 years. AIIMS November 13, AIIMS November 15, AIIMS November 17 and 19. So November AIIMS mostly. So the drug of choice for mild crew is a high dose DEXA. It's a high dose DEXA. It's a high dose. Remember, it's a high dose of 0.6 milligrams per kg. It's a high dose, 0.6 milligrams per kg. Okay. Normally, the dose of DEXA is 0.15 milligrams per kg. Okay. So normally, it's 0.15 milligrams per kg, which we give in meningitis. Okay. We have a student saying, sir, Hindi mein bolo. It is we have students from all across the country and Hindi mein bolna mushkil hai. So phir kabhi. Okay. So for mild, it's dexamethasone, and for moderate students, moderate to severe, you add nebulized racemic epinephrine. So for moderate to severe, I will add nebulized racemic epinephrine. Okay. Okay. Now, if you do a X-ray students, of this child, this is a X-ray AP view of this patient, and I'll try to zoom it for you. If you can see it clearly, I can even highlight for you. What you can see here on your screen is the steeple sign. You're right. You can see that there is actually a narrowing of the airway here. So the steeple sign on a X-ray AP view is a sign of laryngotracheobronchitis. Okay, viral infections are more common. So a steeple sign on an X-ray is one of the marker of laryngotracheobronchitis. Okay, and what about this, students? What is this X-ray on your screen? And your time starts now. I told you, Dr. Azmi, how to look at this patient. So now we have new Dr. Gargi, Dr. Puneet were the first ones to answer here. Okay. Yes, of course, this is a lateral X-ray showing the thumb sign. No doubt about this. So this is a lateral X-ray showing the thumb sign seen in epiglottitis. Seen in epiglottitis. Okay. Remember, on the other hand, like we started with LTP. and we told you croup is viral, croup is mostly mild. On the other hand, epiglottitis is usually severe. It's bacterial. So epiglottitis is bacterial. And remember, all over the world, because of vaccination, now H influenza is rare. All over the world, because of vaccination, H influenza is rare. No, H influenza is rare. So remember, the most common cause of epiglottitis is Streptococcus, okay, followed by Staph aureus. Okay, Strep followed by Staph aureus. If they ask you India, the OP textbook says in India we still have H influenza predominating, but if in your exam, of course in your exam, they're not looking for H influenza as the answer, students, because H influenza is only there in our country because the vaccination is incomplete. However, all over the world, because of the massive vaccination drive, it's gone now. Now this child is a sick child, and all of you are right. This child comes to you with almost no prodrome. So he had no prodrome. Remember, the incubation period is a very short incubation period here, just 1 to 3 days. Incubation period of 1 to 3 days. And this child comes to you with high grade fever, stridor, high grade fever, stridor. You're right, he's toxic. He's drooling saliva. He's toxic. He's drooling saliva. Okay. Okay. And he's almost in air hunger. Okay. He's almost in air hunger. According to the Nelson's textbook, strep pyogenes is more common. Okay. Now remember, airway is the mainstay here. Okay. Airway is the mainstay here. Okay, airway is the mainstay, followed by, of course, it's bacterial, so you have to give antibiotics. So I will give, according to the Nelson's textbook, ceftriaxone with sulbactam. Okay, ceftriaxone with sulbactam. Why would I give sulbactam? Because it will even cover the extended spectrum beta lactamase organisms. Okay, extended spectrum beta lactamase producing organism. Okay, and all of you, if in your exam they don't mention specifically India, then please talk about the world. Of course, in your exam they are talking about the world, not talking about India in your exam. Okay, specifically India pucha jaye, so then talk about India. Okay, and here's the next question. Or before that, are you ready for the next question, students? Hands on your keyboard, because today, by the end of the day, around 7 o'clock, I'll be declaring the winners, the top 2 winners who were very fast in responding. So are you ready for the next question? Ha ya na? Huh? So can we go to the next question? Looks like everyone is not even ready to say yes, because okay, everyone is ready. Cool. So here's your next question. A 1-year-old child comes to you with diarrhea. These are all questions from the DAMS DQB, and I'm sure there are some students who religiously work on this. And so it's a boy with diarrhea for the last 9 days. Along with zinc, what should be given to this child? And Sunshine, Yash and Shoaib. So Yash and Aswathi have told are leading in the race. Sunshine and Shoaib are new ones to come here. Just 1 second. I need to check who was right, who was wrong. I thought I saw Dr. Yash responding. Suddenly it's gone out of space here. So many questions, so many students. So all of you who answered C, you are wrong. Okay, just like in Kaun Banega Crorepati, Amitabh Bachchan says if you answered C, you were wrong. If you answered A, you were wrong. Okay. So most of you who answered B are right. Remember, the treatment of choice for diarrhea in children is, I would again rephrase my word, the treatment of choice for diarrhea, the acute diarrhea in children, is low osmolarity ORS with zinc. Okay. Okay. Yes, you're right. I think Dr. Pandey was the first one to respond. You're right. Dr. Pandey and Divya. You're right. Yash was not actually. I'm not biased. I'm sorry. Dr. Pandey and Divya. Okay. Were the first ones to respond. Thank you, Dr. Chitra, for pointing out. So let's talk about what is acute diarrhea, what is persistent diarrhea. Students, you should know this. What is acute, what is persistent? So according to WHO, acute diarrhea is defined as an episode which starts off as an acute onset. So there was an acute onset. Yeah. Divya got the points, guys. Okay. So there was an acute onset with a duration less than 14 days. With the total duration less than 14 days. Okay. Now remember students that the most common cause of acute diarrhea is viral. So rotavirus is the most common cause of diarrhea in children. Remember the drug of choice for acute. So remember, if it's more than 14 days, we call it as persistent diarrhea. So more than 14 days is persistent diarrhea. Okay. So we use the low osmolarity ORS. Low osmolarity ORS. Remember now, all of you, this is the universal ORS. Low osmolarity ORS is the universal ORS. Universal matlab it is for the whole world. Okay, even Avengers take that. Okay, so it is universal matlab it is for everyone, for children, for adults, everyone. We have to give low osmolarity ORS. Children, adults, viral, bacterial, we give low osmolarity ORS. Remember, the total osmolarity is 245 milliosmoles per kg. And remember 75 milliequivalents per liter of sodium and glucose. So it's 75 of sodium, 75 of glucose. Why am I talking about this today? Because students, in the last ORS the sodium was 90. So in the last ORS sodium was 90. Okay, but then we found, all of you remember that 50 years back in our country we had cholera, and cholera had huge sodium losses. Cholera had huge sodium losses. So 50 years back, 90 of sodium in the ORS was fine. But all of you, now India is not a developing country. Okay, don't say we are a developing country. We call ourselves, an emerging country now. So now we have rotavirus as viral as the most common cause. So if I talk about, the sodium losses. So if I talk about the sodium losses, पहले जमाने में था cholera. Cholera had huge sodium losses, almost to the tune of more than 90 milliclins per liter. But now, in the viral diarrheas, the sodium losses are just 50 to 70 milliclins per liter. Okay. So now we don't need the old ORS because things have changed, even in children and adults. Okay, so we give the low osmolarity ORS along with zinc. So zinc has a lot of evidence, and remember, zinc is, हमारे देश की शान है zinc. हमारे देश की शान है zinc. Because we were the ones who discovered and told. So there was a very big multi-centric study done from All India Institute and many centers in the country, and they found that zinc should be given in all acute diarrheas. Zinc has many advantages. Zinc in acute diarrhea should be given to all children across the world, and now WHO also agrees this. Okay, I remember once I was taking rounds in some country almost 10-12 years back, and I told them that why are you not giving zinc in your patients? So all of them laughed at me. They said, what are you talking about, zinc in diarrhea? We never use it here. And within the next 3 years, WHO declared that we have to give zinc in diarrhea. Twice the recommended daily allowance to all children for 2 weeks. Okay, twice the recommended daily allowance for all children for 2 weeks. Okay, and then I called them back. I emailed them back. I said, look, when I was taking the rounds in your institute, I told you that you are supposed to give zinc. Okay, so less than 6 months, we give 10 milligrams per day. 10 milligrams per day, less than 6 months. And more than 6 months, 20 milligrams per day. 20 milligrams per day of zinc. And as someone said, zinc has many actions, and all of us pediatrician students, we have somehow a passion for zinc. And I don't know, maybe this was one of the cause we got so much mucor in the country. People are still looking at this, so we don't know whether it really works or not. So zinc, it's all because of our passion. We feel that zinc is an immunomodulator. As pediatricians, we have a passion for this. Zinc is a immunomodulator. It enhances the immunity. Moreover, it has been seen that zinc decreases the duration of diarrhea. It decreases the severity of diarrhea. Okay, so it improves the outcome in all patients with diarrhea. Okay, it improves the outcome. It improves the outcome in all patients with acute diarrhea. Okay, so of course you were right in this question when I asked you that if you have a patient with acute diarrhea, you use zinc only with ORS. What about probiotics? Can we give probiotics in diarrhea, students? So there is not evidence. There is no evidence for using probiotics in diarrhea. In fact, students, recently there was a very big randomized trial, and they found probiotics do not work. Okay, So we don't use probiotics in pediatric diarrhea because there is not much evidence on this. Okay, so I will not go for probiotics in a child with diarrhea. What about low lactose diet? What about low lactose diet? Low lactose diet is for persistent diarrhea. So low lactose diet is only for persistent diarrhea. It's not for acute diarrhea. Okay. Today I told you persistent is a diarrhea which starts as an acute episode and is lasting for more than 14 days. What about antibiotics? Remember, we give antibiotics in diarrhea. If a child gets dysentery, dysentery is bacillary. There is no doubt about this. Dysentery is not viral. So if a child gets dysentery, I will give him antibiotic. And I'll start with an antibiotic like cephalexin, a third generation cephalosporin. So dysentery, again, I start with an antibiotic. Okay, don't start with, don't add on metronidazole in every patient. Students, ऐसा नहीं है, dysentery है तो antamoeba है histolytica. No. If it's dysentery, start with a third generation cephalosporin oral antibiotic. If it is not responding, then only go to, metronidazole. Don't give metronidazole to every patient, please. We give antibiotics in cholera. There is no doubt about this. Cholera is the drug of choice is doxycycline. So we give antibiotics in cholera. Last but not the least, we give antibiotics in sepsis. If you have a patient who is sick, who is having sepsis, and he has got diarrhea, I will give him antibiotics as a part of treatment of diarrhea. Okay. Okay, let's go further. And I want all of you to remember this. This is a very important table. A very, very important table. You will definitely get a question on this. How to assess diarrhea? How to assess diarrhea? How to assess diarrhea? Listen. So all of you please listen. First of all, you look at the child, feel the child, and then decide. Look, feel, decide. Look at the condition, his eyes, his thirst, feel the pinch, and then decide. Okay. Ayush, I said antibiotics in dysentery, cholera, sepsis. Okay. Okay, students. So you look at condition. In no dehydration, so according to WHO, students, dehydration is of 3 types. No, some, severe. So according to WHO, diarrhea is of 3 types. No, some, severe. Okay. So if a child is alert, his eyes are fine, he's drinking normally, he has no dehydration. You give plan A. What is plan A? Oral rehydration therapy. So what is plan A? You can give home-based fluids here. So in plan A, you can give home-based fluids here. Okay. It's called oral rehydration therapy. Now students, in your exam, definitely they ask a clinical question on this. A child is irritable. A child is irritable. He is restless. He has sunken eyes. So a child is irritable, he is restless, he has sunken eyes, but he has thirst. So if thirst is intact, this is some dehydration. So students, this table, please look at, if a child is thirsty, And irritable, this is some dehydration, and I will give him ORS. Okay. Thirsty, irritable, sunken eyes. So what is some dehydration? You give ORS. 75 ml per kg over 4 hours. 75 ml per kg over 4 hours. So all of you, a very common question in NEET PG. They will give you even the weight. A 10 kg child after diarrhea is restless, he is thirsty. How much ORS you should give over the next 4 hours? Okay. So then you will write this. Okay. Now come to the right side. Come to the rightmost side, students. Yeah, that's called plan B. 75 ml per kg over 4 hours is the plan B, rightly said. Now if a child is lethargic, he is drowsy, he is not drinking water, he is drowsy, friends, turgor goes back very slowly. So in severe dehydration, turgor goes back very slowly. This is severe dehydration, for which we give intravenous ringer lactate. Yes, Dr. Ashma, if you have ORS at home, you can give ORS also in plan A. For severe dehydration, you give intravenous ringer lactate. Okay. So for severe dehydration, intravenous ringer lactate. So before I talk about ringer lactate, students, I would like to just tell you one more thing, which I and my colleagues who are pediatricians see very commonly. It is very hot outside. So what happens in children? Very commonly we see hypernatremic dehydration. If patient is very, sitting in a very hot area and mother is not feeding him well, in an infant who is starving, on the top of that there is intense heat, you can see hypernatremic dehydration in these children. And remember that these children, turgor is not a good marker for hypernatremic dehydration. They have a doughy kind of feel. They have a doughy feel. You know dough? हाँ? कोविड में रोटी बनाई होगी कभी घर में, हाँ? तो it's like a doughy feel of the abdomen. Okay? Those who made food at home in this COVID era. So remember, in hypernatremic dehydration, we have to correct the sodium slowly. So in hypernatremic dehydration, we give N/2, which is 0.5% normal saline. So we correct the dehydration in hypernatremic dehydration with N/2 slowly over 48 to 72 hours. Slowly over 48 to 72 hours. Okay. Of course, Dr. Ashma, you are right. Every patient we will replace the stools. There is no doubt about it. Okay. If for ongoing losses in every diarrhea, whether it's no or some, you have to replace the stools. Now on your screen, students, why am I saying hypernatremic dehydration? Correct it slowly. Because we want the sodium to fall slowly. If sodium rapidly falls, it can cause central pontine myelinolysis, CPM. We call it CPM. If there's a rapid fall of sodium, we call it CPM, central pontine myelinolysis. So remember, the sodium fall in every patient should not be more than how much? sodium fall, it should not be more than 0.5 milliequivalents per hour or more than 12 milliequivalents in a day. So this is our aim. If you have a patient who comes to you with a sodium of say 170, very commonly I see infants like this in my hospital. So we correct the sodium slowly. The rate of fall of sodium should not be more than 0.5 milliclins per hour, or the rate of fall should not be more than 12 milliclins in a day. Okay. Now all of you, we were talking about severe dehydration, how to correct severe dehydration. It's by intravenous ringer lactate. So remember students, someone was asking, yeah, you're right, both ringer lactate and normal saline are isotonic fluids. Both of them are isotonic fluids. However, remember that most of the times we only give RL for severe dehydration. 100 ml per kg. Okay? Okay, all of you? 100 ml per kg. Less than 1 year. Okay? More than 1 year. Okay? We have to, in a bigger child, you can give it faster. Okay? So initially we give at the rate of 30 ml per kg. Then we give at the rate of 70 ml per kg. So in an older child who is more than 1 year, you can give it over half an hour and the rest over 2.5 hours. Total 100 ho gaya na? Okay, so half an hour and 2.5 hours. Okay, for more than 1 year. For less than 1 year, now here for a child less than 1 year, you should correct dehydration slowly. Don't be in a haste. So over 1 hour, you give 30 ml per kg and the rest over the next 5 hours. Okay. Okay. So remember that. So we talked about zinc, we talked about sodium. And let's talk about the last question of the day. It's related to cardiology. So all of you, are your keypads ready? Because this is the last question which will decide who comes first and second. So this will be the last question of the day. Don't worry, we are always with you for solving your queries. Okay, so this is not the last question of pediatrics or the last question of our interaction. So we are always there. So are we ready? I can tell you Dr. Sethi has already won. She has answered 2 questions in a row. But let's see whether we can have a second and a third position here. Dr. Ashma, holiday seeger is for maintenance fluids. On your screen is deficit correction. Holiday seeker normal बच्चे को देते हैं for maintenance fluids. Okay, now here you have a patient. Here I told you about how to correct the deficit in dehydration. So here we have a question, a child with tetralogy of Fallot. What is the surest sign of a spell? In a case of tetralogy of Fallot, what is the surest sign of a cyanotic spell? And Dr. Chitra is right. And Dr. Aswati is also right. She also told after NEET PG aspirant. So Dr. Chitra and Dr. Sethi. Okay, and NEET PG aspirant, you were also fast, but since they have already answered 2 questions, so let me first take you to spell. So students, those who want to go into the Central Institute, All India Institute or PGI, remember cyanotic spell is a very important topic. Okay, cyanotic spell is it's a very important topic. So first let me talk about tetralogy of Fallot. What are the 4 points about tetralogy of Fallot? So remember what is tetralogy? So there are 4 points about this. So first is it's a subvalvular pulmonary stenosis. So in tetralogy of Fallot, number 1, you have pulmonary stenosis which is mostly subvalvular. It's mostly subvalvular. Okay. Now because of this pulmonary stenosis, there is right ventricular hypertrophy. Okay. Okay. This pulmonary stenosis leads to right ventricular hypertrophy. Okay. Now aorta is overriding the septum. Septum ke upar hai. It's just above the septum. This is aorta. Aorta is overriding the septum. Okay. And lastly, it is a perimembranous VSD. Lastly, it's a perimembranous VSD. Okay. So now because of the pulmonary stenosis, the right ventricular pressure increases. Right ventricular pressure increases. It increases so much that the right ventricular pressure becomes suprasystemic. The right ventricular pressure becomes suprasystemic. Systemic se bhi zyada. So the shunt here is right to left. Can you see? Right to left. So the shunt here is, because the right ventricular pressure is suprasystemic, so the shunt here is right to left. Okay. So remember that. So all of you, the spell which are seen in infants with tetralogy of Fallot are called cyanotic spells or tet spells, or they are very breathless during this time, so they are also called hyperpnic spells. They are also called hyperpnic spells. Okay. And later in life, in older children, there is a history that these children, they squat. So there's a history of squatting episodes in these children. They like to squat. So remember the cyanotic spells or the tet spells or the hyperpnic spells. These children, when they grow, they have a history of squatting. They like to squat on the floor. Okay. Now all of you, the main basis of a spell is a right to left shunt. This is the main basis of a spell. During the time of the spell, the right to left shunt increases. All of you please remember, during the time of the spell, the right to left shunt increases. Okay. Now all of you, look at this tetralogy of Fallot. Can I ask you one more question? Okay, I'll give you, all of you, don't get disheartened everyone. I'll give you one more chance. And my question to you is, out of these 4, which is the most important parameter of the tetralogy? Which is the most important parameter of tetralogy of Fallot? Which is the most important point in TOEFL? 4 baatein. Anyone in the class? which is the most important parameter of TOF? क्या लगता है? Anyone? What is the most important component of the tetralogy? Akansha is right and Thambi is right. So Dr. Akansha, also you have answered 2 times. Very nice. Okay. So you are right that the most important component of tetralogy of Fallot is this pulmonary stenosis. Now all of you, please listen to me very carefully. Please listen to me very carefully. The murmur in tetralogy of Fallot is not because of VSD. Please listen to me. The murmur in tetralogy of Fallot is not because of VSD. It is because of pulmonary stenosis. The murmur in tetralogy of Fallot is a loud systolic murmur here in the left second third intercostal space. It's a loud systolic murmur. It is because of pulmonary stenosis and the amount of the blood crossing the pulmonary valve. So murmur is because of pulmonary stenosis and the amount of blood crossing the pulmonary valve. Okay. So during a spell, students, during a spell, everything is going right to left, right to left, right to left, right to left. So less blood goes to the lungs. Everything has gone right to left. So during a spell, less blood goes to the lungs. Okay. So the murmur disappears. So remember, this is classic of a spell. During a spell, the murmur disappears because less blood goes to the lungs. You're right. Now, since there is increased right to left shunt, there is decreased PO2. Decreased PO2 leads to respiratory center stimulation. So the respiratory center is stimulated. Respiratory center is stimulated. Now there are 3 pathogenesis of a spell. Spell hota क्यों है? The first is, during the time of the spell, the systemic vascular resistance reduces. It has been seen that during the time of the spell, the systemic vascular resistance falls. You know, left ventricle is pumping to the systemics. Left ventricle is pumping to the systemics. Now, if there is less resistance to the systemics, easily right to left, no obstruction to the left, right to left. So it has been seen in experimental models that during the time of the spell, the SVR falls. Okay. Secondly, there is also a dynamic pulmonary stenosis. There is also a dynamic pulmonary stenosis, by which I mean that this pulmonary stenosis is not static. It has been seen in experimental models that during the time of the spell, this pulmonary stenosis becomes more severe. It becomes more tight. Okay, it becomes more tight. So right ventricular pressure increases and the right to left shunt increases. Lastly, this child is crying. Crying also aggravates cyanosis. So crying also aggravates cyanosis. You know, whenever you cry, before you cry, what do before you cry? You take a deep breath and then you cry. Bheh. So, you know, crying increases the venous return. Inspiration increases the venous return. So the right to left shunt increases. So let's talk about how do you first diagnose a spell. So मैंने कहा during a spell a child is irritable, he is tachypneic, and the murmur which was very loud disappears during the time of the spell. So to treat a spell, and now we understand Why he was squatting? Because whenever you squat, your abdomen is compressed, your femorals are compressed. So whenever you squat, your systemic vascular resistance increases and the right to left shunt reduces. So the right to left shunt reduces. Okay. So life taught him, all of you, not everyone, has a mentor like, Damsonians. So, बहुत सारी बातें आपको खुद सीखनी पड़ेगी. If you're alone studying, like I told you, like look at this child. This child learned by himself in his life. Ki guys, if I squat, my right to left shunt reduces. So कुछ बातें, जिंदगी खुद सिखा देती. Someone wanted me to speak in Hindi. So कुछ बातें दोस्तों जिंदगी सिखाएगी आपको. So जिंदगी सिखाएगी इस बच्चे को. Life taught him this, that he needs to squat. So in the emergency, guys, we keep him in a knee chest position, just like squatting, all of you. So in the emergency treatment of a spell, keep him in a knee chest position. Give him ketamine to increase the SVR. Give him intravenous phenylephrine to increase the SVR. Okay, give him ketamine, give him intravenous phenylephrine. For oxygen, he was hypoxic, so I will give him oxygen, and I will give him intravenous sodium bicarbonate. I'll give him intravenous sodium bicarbonate. It has been seen when you're hypoxic, you get acidotic. So I will give him intravenous sodium bicarbonate. Okay. So it has been seen when your PO2 is less than 40, you become acidotic. When your PO2 is below 40, you become acidotic metabolically. So you give intravenous sodium bicarbonate. To suppress the respiratory center, I will give him subcutaneous morphine to suppress the respiratory center. For the dynamic PS, I will give him intravenous propranolol. You're right. I'm sure, Dr. Ayush, you are my student, because this pathogenesis is not given in any book. It is not there in OP Ghai textbook. Okay. So if you read, there are many pediatric cardiology textbooks like Moss and Adams. So this pathogenesis is there in both those books. It's not in the conventional books. And there it's written that propranolol maybe acts via reducing the dynamic pulmonary stenosis. So you're right that if you understand the pathogenesis, then you know how to treat a spell also in tetralogy of Fallot. So this is the masala which we give to this child who has tetralogy of Fallot. Okay. So that was all for the day. I can go on and on for days if you want me to teach you, but that was all for the plan for the day for the pediatrics quiz. And I am very happy, all of you, that you were very interactive and all of you were answering very nicely. And I'm sure half of you are our DAMS students. So Damsonians, you will do well, I'm sure, in the next month exam and also in the NEET PG. So on behalf of the DAMS family, I wish you all the best. Any comments, anyone? By the way, Dr. Akansha, Dr. Chitra and Dr. Aswathi performed very well. Dr. Yash also, you were also very interactive. Okay. It's not about who won, who lost. Okay. It's about being together in these difficult times and still winning. Okay. So students, any comments? We look forward to more interactive sessions on the YouTube and the Facebook. And on the Facebook, students, I'm on the DAMS exclusive club. On the DAMS exclusive club, I'm very fast in responding. I'm at PDF for PG on the Facebook and the DAMS exclusive club. By the way, my name is, those who are new to DAMS family, my name is Dr. Sidharth Sethi. I am the pediatrics faculty, and also I'm a pediatric nephrologist by my profession. Thank you and all the very best. And I'll see you soon on the other side when we will be scolding you, when you will be juniors to us, and we'll be scolding you while teaching you. Okay, thank you. Please, if you're Damsonians, please look at the DAMS exclusive club. All the questions, all the topics are categorized. Just go to the topics, look at the topics: neonatology, pediatric cardiology, pediatric nephrology, pulmonology. I have categorized all the topics on the Facebook. Please look at those topics on the DAMS exclusive club, 2020, 2021, wherever you are. Okay, thank you.